So I pretty much had a crazy night in the Bronx. Once again, we popped the narcotics 2 times. Stay tuned to this video. I'm gonna tell you the best practices when using narcotics. Check it out. So why is using narcotics 2 times in one tour such a big deal is because I'm the type of paramedic where you have to earn the medication that you're going to receive from me. I'm not gun-ho. I'm not the type to say, oh my God, they fit into that very small part of the algorithm, so let me go ahead and give them all the treatments available with that algorithm. There's a lot of times where healthcare providers, they get some kind of personal satisfaction from doing what's in the protocol. They go all out and start intubating people with a pulse ox of 90 when they could have just bagged them. So it's a very big deal for me to go ahead and give narcotics 2 times in one shift because of what I previously mentioned. And this happened in the South Bronx. Once again, the Bronx strikes again. And in one overnight shift, this is what happened. The very first person that needed a narcotic medication was a lady who was a tight asthmatic. BLS called for backup. They even gave her epi before we arrived because she had such a difficult time breathing. She was cool, pale, diaphoretic, and she was a really, really tight person, pretty much status asthmaticus. But then, before we got there, the BLS noticed that the epi started to work. She started to breathe better, but she became combative when we arrived, trying to take her to the hospital. She wasn't trying to hear it. We tried to lead her to the stretcher. She wasn't trying to hear it. And the worst thing about it was she had like some kind of psychiatric history, some kind of dementia that didn't allow her to be alert times person, place, and time. And we couldn't get a refusal of medical attention, so we pretty much were forced to take her to the hospital, even though she was communicating to us that she didn't want to go. And the way we handled it was, we went ahead, we tried to explain to her what was in her best interest, and it was just not registering. So we went ahead and put her on the stretcher. She became combative. She started slamming. We tried to use cravats to keep her hands in place. We tried to use the straps on the stretcher. Nothing worked. This is indication number 1 for the need of a narcotic for excited delirium. It's you have to give the medication because it's in the person's best interest. She was working herself up. Her pulse ox went from 70 something to 90 something, but then it was going back down every little time that we were able to measure it because she was getting worked up. She was exerting herself. She went ahead and started getting into wheezing due to the stress. What did we do? We went ahead and gave her a medication, midazolam, intramuscularly. Called telemetry, let them know what was going on, and we gave her a narcotic that helped her calm down because she was working herself up. After the narcotic kicked in, we put the nebulizer treatment with ipratropium and albuterol. She started breathing better. She started stabilizing a lot more. Had we left her as is, she would have gone into a hypoxic seizure, hypoxic something, and we probably would have ended up going into respiratory failure and having to intubate her. And why do I bring this up with so much detail? Because these are the factors that indicate the need for a medication that's that's like being controlled by the Drug Enforcement Administration. You can't just start giving out narcotics because you have the right to. I always said it, and I'll say it again. Just because you could doesn't mean you should. So you arrive on scene and you'll have police officers trying to talk you into giving a narcotic. You'll have BLS EMTs trying to talk you into giving a narcotic. You even have your partner trying to talk you into giving a narcotic when you could just use people skills. A lot of times, people skills will help ease the discomfort on a call, and a lot of times it doesn't. And that's when you resort to that medication. like in that lady. And then the following call, a few hours later, we go to this place where this guy had a seizure. He woke up and he was combative. He didn't want to hear about us taking him to the hospital. Although he had urinary incontinence, he was alert and oriented times 3. The room was filled with police officers. Just imagine a room. The only thing it had was a fan and empty beer bottles, empty beer cans of the cheapest ones. This guy was sleeping on the floor. Urinary incontinence. Apparently an alcoholic. Was it? And he had a seizure history. Did he have DTs or was it a seizure? Whatever. We had to take this guy to the hospital and he wasn't trying to hear it. How did I handle this? I spoke to him, let him know that we're trying to help him. We're here to try to help him with his problem. I try to mention the fact that the hospital had a cushy bed for him. I try to mention the fact that the hospital is going to have a sandwich and it's going to be warm and he could go over there and shower up and just freshen up and he didn't have to sleep on the floor. So I try to speak to him and remind him, like, we're here to help you. What do you want? Do you want some water? Do you want some water? Who do you want to call somebody? Can I help you with your belongings? I'll carry that for you, bro. Don't worry about it. I got you. And the funny thing was, this guy was in the Bronx, so I was able to communicate with the slang that us New Yorkers have and we already know all too well. And it didn't work. I treated him like a brother. It didn't work. He was still combative. We put him on the stair chair. The police officers were trying to hold him down. He was fighting everybody. And then he got midazolam, intramuscularly. Again, same as the lady, on the same shift. And why did he get it? Because his movement on the stair chair was making the stair chair pretty much prone to falling, and the only thing that will stop it from falling is us bracing the fall. And usually bracing the fall would include us using our lower back. We could hurt ourselves, the patient could hurt themselves, the other first responders could hurt themselves, and we don't want anybody to get hurt. So what do? We give him midazolam. He calmed down, he relaxed. We put him on the EKG, took his blood pressure, did a 3-lead, put a nasal capnography on him, the whole shebang, and transported him with no issues. So, in those cases, those 2 previous cases, we could and we did because we should. We needed to give these people the narcotic medication. Everything that we tried didn't work. All the BLS maneuvers, all the people skills, all the empathy and the patient advocacy did not work. And that's when you know that you should give a narcotic medication. I've had women, like I remember this old elderly lady, she was APE up to here, blood pressure through the roof, and she was just frothing at the mouth, and she had a really hard time breathing. And she had the CPAP on, and I told her, ma'am, you need to relax, and she was very anxious. She couldn't breathe, and she was feeling the anxiety from not being able to breathe. And I whispered in her ear. I told her, miss, listen, if you don't relax, you're going to go into respiratory failure. You're going to stop breathing. You're going to run out of oxygen, even though we're giving you oxygen. And then I'm going to have to intubate you. And you're 70-something years old. You're going to end up in a nursing home and you're probably going to be on a ventilator and you're not going to get off of it, as per the stats. This is what I told her in Spanish, in her ear. And what did she do? She relaxed. We didn't have to intubate her. So what I'm trying to tell you is, narcotics are a great tool. You should use them when you have to. And when you exhaust all the previously mentioned things that I mentioned in this video, if they still don't work, then you gotta do what you gotta do. I hope this helps. Peace.